At the outset, I'd like to thank Dr. Lita and her team for inviting me here. Now, my talk is on evaluating and treating normal tension glaucoma. But before we go into managing normal tension glaucoma, I'd like to tell about few salient features of normal tension glaucoma. Before you label a person to be having normal tension glaucoma, there are few things that you should do, and even more things that you should, rule out. It's a diagnosis of exclusion. It doesn't behave like hypertensive glaucomas, but for all practical purposes, it's theoretically included under primary open-angle glaucomas. So one of the primary things that you have to do is do a gonioscopy. Make sure that the angles are open. Only if you do that can you label a person as normal tension glaucoma. And how is it different from other glaucomas? Well, the IOP is consistently within the normal range, which brings us to the second thing that you should do, and that is the diurnal variation or phasing. Now, this is taken from my colleague CMR, and she has done a office DVT. Probably this is enough rather than doing a 24-hour DVT. Make sure that the fluctuations are less than 6 millimeters, and make sure there is no peaking of IOP at any point of time. Coming to the pathogens of glaucomatous optic neuropathy, in hypertensive glaucomas you have mechanical, vascular as well as neurodegenerative theories, but most of them you can always relate to the increased intraocular pressure. While in normal tension glaucoma, almost always IOP independent factors are involved, and we shall come to these few factors later on in the talk. So these are the factors which lead on to NTG. And if you see a person whom you suspect to be having NTG, always rule out most of these factors that I mentioned here. One is burnt out glaucomas. Now, what are burnt out glaucomas? Burnt out glaucomas are those glaucomas which are no longer active. Like probably a person who used steroids earlier on. Now they are not using steroids, the IOP has come down to normal. Or there was a trauma which caused a hyphema, and that is now no longer there. The glaucoma is not going to progress. It could be a burnt out pigment dispersion. Again, that is probably not going to progress. So always take a proper history when you have a patient whom you suspect to be having normal tension glaucoma. That is very, very important. You have to always rule out conditions which you don't need to treat and which is not going to cause any progression. Dysplastic optic nerve head, as Dr. Lita was saying, there could be dysplastic nerve heads which you might feel it may be glaucomatous, may appear glaucomatous. It's just that the disc is like that. Always it has been like that. So always take a photograph and make sure there is no progression. There are non-glaucomatous causes for cupping. A whole list is there. Like all these causes, you might feel that the disc appears glaucomatous, but make sure these are not there in this present individual that you are seeing. Now, what are the ocular features that are associated with normal tension glaucoma, which are more common in NTG patients rather than in hypertensive glaucomas? I've already mentioned the normal IOP and open angles, but most of these patients also have thin corneas, and their optic nerve heads are rather larger in size. The cupping is more sloping. It's kind of a saucer-rise cup, and you may not be able to exactly locate where the NRR ends and the cup begins. Usually, the inferotemporal aspect of the disc is involved. The RNFL loss is usually localized, and it is more closer to the center of fovea. Again, inferior margin is usually involved. When you do an OCT of the ganglion cell complex, you find that the the inferior half of the ganglion cell complex is more thin. Peripapillary atrophy is more common, and it's more larger, it's more prominent in normal tension glaucoma patients compared to hypertensive patients. Disc hemorrhages are way more common in normal tension glaucomas, and probably they represent some sort of vascular dysregulation at the optic nerve head level. There is increased chance of progression in such patients, and the ominous thing is that there is already a worsening of the visual field defect when you see this. So disc photographs are very, very important. You have to note that the glaucoma, whether the patient is having disc hemorrhages. The visual field defects are usually steeper and deeper in NTG patients. They are more central, and superior defects are more common. And typically the fields are worse than what you would expect from seeing the disc on the slit lamp. And it gets worse if you have migraine or you have a disc hemorrhage in between. So this is one of our patients. Earlier it used to be called Deringer fields, this sort of a field. I don't see that term anymore, but it's like a shape of a gun. So these are typically seen in NTG patients. Now, many studies have focused on the lamina cribrosa, and it was found that the lamina cribrosa is significantly thinner in NTG patients. And this particular study, they found that the lamina cribrosa is only almost half of what it is in the normal controls. It is thin in POG patients also, but significantly more thinner in NTG patients. Now, when the lamina cribrosa becomes thinner and larger, the problem is that the stress on the lamina cribrosa increases. And the thinner parts of the lamina cribrosa become more prone for damage, and this is typically the inferotemporal or the supratemporal part. Coming to the systemic associations, numerous systemic associations described with NTG, and most of them are vascular abnormalities, including nocturnal hypotension, vasospastic disorders like Raynaud's phenomenon, migraine, vascular dysregulation, which may be either systemic or a localized ophthalmic finding, reduced blood flow, which may be again retroocular or involving the cerebral system also. And cerebral microinfarcts have also been seen in patients with NTG. Now, the fact that impaired ocular blood flow, it causes increased vulnerability to glaucoma. That has been known for more than 50 years now, but this is more prominent when you have a patient with NTG. And disc hemorrhage, it has been associated with low systolic BP, low ocular perfusion pressure, migraine, systemic beta blocker use, uncontrolled diabetes, hypertension. All these can cause appearance of disc hemorrhages. Now, initially the diagnosing reduce in ocular blood flow was not very easy. You had to use invasive methods, but nowadays it is much better. You have various technologies that you can use to diagnose whether the patient is having a good ocular blood flow or not. And many studies have shown that the visual field loss correlated with the ocular blood flow. Also, on OCT, you can see that the peripapillary capillary density is much less in NTG patients. One important parameter is ocular perfusion pressure, which is the difference between the arterial BP and the intraocular pressure. Most NTG patients have fluctuations in this ocular perfusion pressure, and this leads to an unstable oxygen supply to the nerve tissues. This in turn leads to perfusion, reperfusion injury and oxidative stress. Ocular perfusion pressure as a single parameter is probably not an ideal one, but it has shown that it correlates with progression in NTG. Another factor that is becoming more prominent is resistance to ocular blood flow in the form of increased retinal venous pressure. This again is a manifestation of dysregulation, and such patients have increased endothelin and homocysteine levels. This could also be a part of systemic venous dysregulation. They have introduced a syndrome called Flammer syndrome, which is persons who have very cold extremities, low BP, and they are extremely sensitive to temperature, all sorts of pressure, vibrations, extremely sensitive people. They have instability of ocular blood flow as well as the perfusion pressure, and it was shown that L-methyl folate improves the situation in such individuals. Coming to other associations, one important one is nocturnal sleep apnea, which is now being, it has been associated with many systemic problems, impaired CSF circulation and also decreased CSF pressure, which brings to the next important aspect in NTG, that is the association of intracranial pressure with the normal tension. So this is a line diagram showing the sclera. The lamina cribrosa, the dotted line is the lamina cribrosa, and on one side you have the intraocular pressure, and the other side you have the intracranial pressure that is surrounding the optic nerve head. So the stress on the lamina cribrosa is given by that formula, where P is the difference between the pressures and R the radius and T the thickness. So if you have a large thin lamina cribrosa, the stress on the lamina cribrosa increases manifold. And as age increases, problem is that the sclera becomes more and more stiff, while the pressure remains the same or maybe even increases, and the tension or the stress on the lamina cribrosa increases as the age increases. So do NTG patients have lower intracranial pressure? That was what was checked into by these studies, and they found that the ICT is comparatively lower in NTG patients as compared to POAG or even in controls. And visual field was also significantly associated with translaminar pressure gradient, whereas the intraocular pressure and the ICT alone were not significantly associated. This is the corollary. Can lowering ICT cause the patients to be more prone for NTG? So again, they did a study on patients who had undergone shunt procedures. So they found that they kept the opening pressure of the shunt, and the longer duration they had from the shunt placement, patients did go on to develop NTG. A word about the normal tension glaucoma study. It came around 1998 or something. So they divided 140 patients with progressing NTG into two arms. One arm they treated and reduced the pressure to less than 30% of the baseline. And at the end point, they found that the treated arm had significantly less progression. But the natural course was highly variable. Many patients who were treated and who maintained the IOP less than 30% progressed, while many persons who were not treated did not progress also. They found women and migraineurs and those with disc hemorrhages had a higher risk of progression. Coming to the management, this is a small flow chart. So if you have a person who you feel that has normal tension glaucoma, always take a detailed history, rule out risk factors for glaucoma, rule out if anybody in the family is having glaucoma, do a diurnal variation, and if you find that there is a fluctuation that is more than what you would expect, more than normal, then you can go in for a unilateral drug trial. Always do the baseline glaucoma tests, take a disc photo, and look for progression. If there is again progression, you can add drugs, you can do lasers, you can do trab. If there is no progression, you can follow up. If the diurnal variation is normal and you don't feel that it is going to progress, you can again follow up using the usual parameters. If there is progression, you have to exclude other factors, other treatable factors, maybe migraine, uncontrolled hypertension, or a hypotensive patient, or a nighttime BP drug that is being used. And again, you can go back to the unilateral drug trial. There is no progression at all, then you can always reassess, see for fields, and some patients you might need a neurology consultation. Coming to the treatment per se, you can aim for a 30% reduction, and probably prostaglandin analogs are the single drug that can get to your target IOP. Laser trabeculoplasty is good, primary as well as secondary options, but it's unlikely to be successful by itself, but it does reduce a number of medications and reduces fluctuations also. Surgical indications are when the target is not reached and there is progression despite maximal medical therapy, there is difficulty in compliance, there is adverse effects to medicines. Trabeculectomy is the procedure of choice. Drainage devices usually reserved for the next step, and MIGS usually again similar to laser trabeculoplasty. You can reduce the number of medications. Probably you can try that out. Now in normal tension glaucoma, other factors also you have to give some importance, like cardiovascular problems. Whether the patient is having anemia? Are they having any arrhythmias? So these are things that you may not worry too much about when you're treating hypertensive patients. But a cardiology evaluation probably is required in such patients, and you have to always individualize patients how you manage them. Diet, vitamin supplements, ginkgo biloba, all these were found to have positive effects. Not really, no real studies to make sure that you give them, but you can always inquire. Exercise, yoga, whether the patient is stressed out, anxious, jobs, always inquire. When do you send for neuroimaging? Well, you have a patient with headache or other neurological symptoms, decreased or fluctuating vision, a typical visual fields, a typical rate of progression, pallor more than cupping. All these patients you have to send for a neuro consultation also. So this is a patient whom I've been following almost for around 10 years. There are no systemic problems that I could associate with this patient. And the pressure is almost always less than 15, 16, 15, that sort of a range. So initially she was started on Salatan from elsewhere, already 10 years diagnosed glaucoma. Every 3 to 4 years I had to increase the number of medications. And from around Jan, I have been advising, Jan 2021, advising TRAB in the left eye because that eye was progressing faster. So she finally did that in May 2023, so around 2 years later. So these are the fields. Left eye was progressing quicker. Right eye is the worser eye, but progression is not that much. This is the IOP graph. Following TRAB, it has come down to around 6, 7, 8, that sort of a pressure. Not done fields after that, hopefully it should be stable. These are my references. Thank you.
Thank you very much, Dr. Abhilash, for the excellent talk and really highlighting all the confusions that face us when we manage a case of normal tension glaucoma. May I ask, I've got a few patients with valvular heart disease, not arrhythmias, who are again typically progressing like in this sort of. Have you seen similar cases?
Valvular heart disease, not really. But I have sent a number of patients for cardiac evaluation when I suspect that there may be something more than glaucoma. I had one patient who had eclampsia, and that patient had a problem with the fields and the disc. But again, probably I won't read that because that passes off once she, delivers. Valvular heart disease, I have not had any patient.
And we have, you also talked about the role of intracranial pressure. We have a very nice question from Dr. Baburaj. The role of variation in intracranial tension in the causation of glaucoma. So I think you have highlighted, you can just briefly.
Now, the problem with these studies is that you are taking intracranial tension in a lateral lying position. Almost always the LP is done in the lateral lying position. Now, whether that pressure is the same as the optic nerve pressure in the supine position, where we spend most of the time, and whether the pressure inside the optic nerve is the same as the pressure inside the sheath that covers the optic nerve. So these are all controversial subjects. These are debatable subjects. But what was shown is that even if the intracranial tension was taken in the lateral decubitus position, it did have a significant impact on the glaucoma progression. So if the ICT is lower, they found that the progression is faster. If the ICT is higher, it causes a reverse problem. It causes edema of the optic nerve head. You call it papilledema. If it is the opposite way, it causes the lamina cribrosa to shift backwards. So that causes increased cupping and glaucoma happens. Or other field changes happen. You don't know if it's glaucoma, it can be termed glaucoma or not, but patients do progress with field defects and disc changes. So that's what probably the conclusion is. Though there are very many caveats to the analogy of comparing ICT to glaucoma.
Thank you very much, Dr. Abhilash.
Thank you.